view on thing, right?
Good afternoon, and thank you for joining us for this collaborative and interactive webinar, Flipping Off the Switch on Hot Emergency Medical Vehicle Responses. This session is being recorded and streamed live. If you're accessing this session through the Zoom platform, please use the Q&A function to submit your questions. You can identify the Q&A function by the double dialog bubble button. The chat function in Zoom should be used for peer-to-peer resource sharing or for asking for technical assistance from our moderator. If you're viewing this session on Facebook, please like and share the stream. You can submit questions in the comments section of Facebook to be addressed by our panel. With that, it's my absolute pleasure to turn things over to AIM High Education Committee Chair and former NAEMT President, Matt Zavatsky.
And there's no better title than former EMT president. Thank you, Amanda. Great job getting us kicked off. And I just want to say what a great response it has been for this webinar. It is obviously a very a topic that people really want to hear a lot about. And we have an amazing group of panelists here that are going to be joining us, and some doing some formal presentations. One of the things that we should note is the number of different organizations that have come together to put this program on for field providers, system leaders, because it is such an important topic, certainly for the safety of our personnel and for the safety of the public. So what we want to do real early is get right into a great discussion from Dr. Kupis, who was the primary author of a landmark study when it comes to red light and siren use in emergency medical vehicles. So Dr. Kupis, take it away.
Thanks, Matt. And hi, everybody. My name is Doug Kupis. I am an EMS and emergency physician with Geisinger Health System in central Pennsylvania. I also serve as the Commonwealth EMS Medical Director for the state of Pennsylvania. And it was an honor to be asked by NHTSA to do this monograph back in 2017 now. And my intent is to just spend a couple minutes setting a baseline so that we're all sort of on the same page about what the problem is and why we're even talking about flipping off the switch. Next slide. So, it can be debated as to how many crashes occur that are in emergency medical vehicles each year. It's been estimated about 12,000. And again, if it's a little higher, a little lower, the fact of the matter is that we have crashes of EMS vehicles every day. And the fact of the matter is that often those crashes are related to the use of lights and siren. That doesn't take into account the fact that there's an estimated 4 wake effect crashes for every one that involves the emergency vehicle. That's when, the emergency vehicle goes through a traffic signal and other vehicles collide with each other because they're disrupted because of the flow of the emergency vehicle. And, any of these crashes don't lead to our ultimate goal of serving our patients because they delay responses, they cause other resources to have to respond to the crash, and are devastating for an agency. Next slide. So, I just want to point out one article because there are a couple hundred articles in the monograph, but there's one that was published since the monograph by Watanabe that basically showed that there is a distinct relationship between the use of lights and siren responses or transports and crashes. Your crash rate goes up by 50%. 53% if you are responding with lights and sirens, and an interesting almost 3 times the chance of a crash when you're transporting with lights and sirens. So, Watanabe was the first to really show that these crashes are linked to the use of lights and siren operations. Next slide. Back during the study, we put in some information from NEMSIS that was gathered from all the NEMSIS data across the country, 15.7 million 911 responses that led to transport. And in 2015, 76.5, almost 77% of those across the United States were done with lights and siren. And 22.7, nearly 23% were transported to the hospital with lights and siren. Both of those numbers are, by the evidence, much higher than they should be. Interestingly, they also vary by urbanicity, but they varied by a factor of about 20% based on which US Census division you're in. So, much of this is local culture rather than, evidence and need. Next slide. This graph shows you during response, every agency that submitted those 15 million calls was plugged in by agency to how often the agency used lights and siren during response. And you can see that in the response phase, they're very heavy on the end of agencies that use it 100% of the time for every 911 response, or more than 90% of the time. Next slide. If we break this down, we find that only 17% of agencies in the country were going to less than half of their calls with lights and siren. Next slide. And there are agencies that have been creative, both big and small. EMSA in Tulsa, Oklahoma, revised their response time requirements. And instead of using an 8-minute response time like many agencies do, they revised their response time requirements both for the high severity cases and low severity cases. And that dropped their lights and siren responses to about 33%, almost exactly 1/3 of their calls. My personal experience is that for the last about 20 years in my community, my EMS agency has been going to about 20% of their calls with lights and siren. This is their 911 emergency calls. Next slide. We know that lights and siren does not save much time. This is the world's literature on time savings from lights and sirens during response. And in the response phase, that time savings is anywhere from 1.7 minutes up to about 3.6 minutes. No matter how you slice that, for the vast majority of people that call 911, that is not a life-saving amount of time for most conditions. Next slide. So in the paper, we made a suggestion that a benchmark is that agencies should be trying to cut their lights and siren response to at least less than half of their 911 calls going lights and siren. Again, I think that agencies have been lower than that, 20%, 33%. 50% shouldn't be the ultimate benchmark, but if you're doing more than 50%, you should at least try to cut that down to less than. And if you're doing less than 50%, you should try to reduce it even more. Next slide. I love this statement that was made in 1980 in a paper that they did in Connecticut when they surveyed the public as to why they don't call 911 when they're having a serious emergency. And lights and siren and lots of attention were the top 2 reasons why people with significant emergencies chose not to call 911 and preferred to go to the emergency department privately. And E. Marie Wilson made this comment in the paper: competence is more often showed by quiet deliberateness than by noisy bravado. And I love that. Next slide. This is my last slide. I just sort of want to summarize this. Lights and siren use is a medical intervention. We should be turning on the lights and siren the same way we decide whether or not we give a drug or an IV or something like that. If the patient needs it and will benefit by it, we should use it. If the patient's not going to have any benefit, then we shouldn't be applying it to everybody. Like I said, the paper suggests less than 50% of 911 responses and less than 5% of transports as a benchmark to shoot for agencies, knowing that it probably is closer to almost no transports should be done with lights and siren, and you can get much less than 50%. Lights and siren transport really should be a sentinel QI event, just like an intubation. Agencies should look and say, why did we transport with lights and siren, and actually do a QI review of that. EMD protocols are extremely important in helping to define which groups of patients by evidence and outcomes should get lights and siren response. And, I want to close by just saying this is everybody's responsibility. It's the dispatcher, it's the EMS vehicle operator, it's every EMS provider that's medically determining if their patient needs to save 2 minutes to get to the hospital. It's the first in units that can tone down other units, and it's medical direction and QI providers. So I'm looking forward to the rest of our discussion with the Niagara Falls folks.
Thank you very much, Doug. I'm going to take over from here and chat for just a couple of minutes. I'm John Kramer. I'm the director of the Office of EMS at the National Highway Traffic Safety Administration, and want to take just a couple of minutes to chat with you very briefly about a report that we have recently completed and hope will be published within the next couple of months that focuses really on a subset of ambulance motor vehicle crashes. Doug alluded to this very briefly, but in the study period of this report, the study period of the report that was originally done was from 1992 to 2011. And this report that I'm mentioning to you right now looks at the time frame from 2012 to 2018. So we are still a couple years behind current reporting. Anecdotally, it is apparent that ambulance crashes are continuing at an unacceptably high rate. So we will follow up with that in the coming years as well. But in this report that will be coming out shortly, looking at the 2012 to 2018 time period, we're still experiencing a rate of about 25 fatal crashes a year, resulting in 29 fatalities from those. And I need to qualify this because this study is looking at a subset of all of the ambulance and all of the fatal crashes that have been investigated by the NHTSA Severe Crash Investigation Unit. Next slide, please. If we look at the types of individuals that are killed in these fatal accidents that were included in this report, the majority of them are occupants of other vehicles, as you can see here. But we do have ambulance operators and either patients or other caregivers, which is the category of ambulance passengers, significantly involved in these crashes. The next slide, please. If we look at the use of lights and siren associated with these crashes, you can tell by this slide, 32% of the crashes that we looked at involved the use of lights and siren during either the response or the transport. So looking at those numbers positively, a majority of the crashes don't involve lights and siren, but still a third of them do. So looking at the issue of the impact of lights and siren, we can still significantly influence the results of those crashes. Next slide, please. If we look at those crashes that result only in injury and not in a fatality, again, the majority of those involve occupants of the other vehicle, 2/3 of those cases. But the ambulance operator and passengers are significantly affected even in injury-only accidents. Next slide, please. And looking at the use of lights and sirens in those injury-only crashes, 1 in 5 still involve the use of lights and siren. So if you look at the overall incidence of crashes and the magnitude of the injuries and deaths associated with that, addressing the issue of lights and siren will significantly still impact the number of injuries and fatalities. Next slide, please. This is an infographic that we put together from the original report, 1992 through 2011, just noting that there was an average at that time of 33 fatal injuries per year. And if you remember the comment that I made just a second ago, we're now with this new report at about 25 per year. Still way too many and an impact that we can have. This is a little bit peripheral to this lights and siren discussion, but I want to point out 2 other important facts from both the previous study and the study soon to be released. 84% of our practitioners during the response or transport, primarily during the transport when they're in the patient compartment, were not appropriately restrained. And only 33% of our patients were appropriately restrained. The next slide shows what we've found with this most recent study. I think I mentioned a minute ago 25 fatalities. It should be 29. I apologize for that. But 29 fatalities on an average per year. In those fatal incidents, 91% of our providers were not restrained, and 17% of the patients, only 17%, were appropriately restrained to the stretcher. So we're focusing obviously on lights and siren use here and the impact that that can have. But please, as a side note, please make sure that our clinicians, our staff, and the patients are appropriately restrained in the vehicles. Again, we're hoping this report will be released in its entirety within the next couple of months. I'd now like to turn it over to Chief McAvoy from Saratoga County. Mike.
Hi, I just want to talk very briefly about a change that we made in our response. We, in Saratoga County, about 150 miles north of New York City, answer about 31,000 EMS calls per year, serving a population of about 250,000, spread out over a 855 square mile area. If you add in interfacility transports, I think that call volume goes up to about 41,000 per year. And what we did back in 2018 was we asked the School of Public Health to take a look at a call type, the Bravo determinant that some of you are probably familiar with. We use a medical priority dispatch screening system where calls are categorized as Alpha, Bravo, Charlie, Delta, and Echo. We then assign a response mode to each one of those. And we took the Bravo category and asked the School of Public Health really to do an 18-year review of those calls and look at the potential to perhaps make it safer for our providers and to reduce the wear and tear on vehicles, but also not affect patient outcomes, which is most important to our providers. We took those calls and using multiple data sets, including hospital data from the Department of Health, charting data, NEMSIS data. Next slide, please. Looked at those calls for that period of time and realized some very interesting things. Of the total number of calls, a significant number of those people were not transported. And then of that percentage that were transported, the 37,000 patients over that period of time, 1.5% of those, or 565 of those individuals, actually got admitted to the hospital. Very, very low percentage. And 3 of them, which is almost statistically difficult to calculate, 3 of them were admitted to ICU beds. So our conclusion from that back in 2018 was that we could very safely take that entire call class and translate it from something that often responded with the first unit as a hot mode to making everyone respond in that mode, non-emergency, and hopefully decrease the risk to our providers and do that without affecting outcomes of patients. And obviously this is the quality study, it's a little unscientific. It probably doesn't encounter or take into account interventions at the scene, what those did to patients. It doesn't look long-term at outcomes of those individuals. But since we made that change a couple of years ago and continue to go back and look at that, we have not found any significant changes in the outcomes to patients. So I'd like to turn it over to our next presenter. Two folks who kind of have the meat of our presentation today, Chief Kevin Smith and Deputy Chief Rick Farron from Niagara area of Canada, to talk about how they made a switch on their hot responses. Gentlemen.
Thank you very much, Mike, and thanks for having us here to talk about this very important topic. As mentioned, I'm Kevin Smith, Chief for Niagara Emergency Medical Services, located in Southern Ontario in Canada. And joining with me is Deputy Chief Rick Farron, who's our Deputy Chief of System Performance, who will be joining me and providing some information. What we're going to talk about, I'm going to tell you, is very complex and deep. We're going to move very quickly through a lot of important information. So, whatever we don't get through today, certainly we're available afterwards if anybody is interested in more information. The system that we're going to talk about today is really about a systems change. If you could just stay on the first slide there for a moment, Amanda. It's really about a systems change and not about lights and sirens. That component is actually just one part of a broader system change that we made. Getting to a point of having only 10% of our call volume responded to by lights and siren by policy is just one aspect of a broader system change. So that's really important to understand as we move through this. It's not just a singular change that we made. And with our system, historically, we know that EMS has been measured on time and being fast as the main things we measure performance by. But as the title says, it's better to be right than fast, and sometimes it's right to be fast. And this service delivery model that we implemented in our service, we did so because it was the right thing to do for our community and our staff. So this is not to say that what we're proposing is a solution for every community and every agency. You need to do what's right for your constituents, with the emphasis on doing what's right and not doing what's always been. And we know that right actually means making evidence-informed decisions and not decisions that are based on individual wants or needs. Next slide. Thanks, Amanda. So a little bit about the service. For those of you not familiar with the Niagara region in Ontario, we are bordered in the Great Lakes with Lake Ontario to the north and Lake Erie to the south. We're a border community to Buffalo, New York to our east. And so, we're very much independent on our own and needs to be self-sufficient in providing emergency coverage in our region. We are an accredited center of excellence for both NPDS and ECNS. We operate both a mix of ALS, BLS vehicles and units in Ontario. That's advanced care paramedic, primary care paramedic. We are a 911 only service, so any of the intrafacility non-urgent transports are actually done through private services. Next slide. So it was said recently, and I thought it was catching that, reducing lights and sirens is, it's like we're taking people's birthdays away. And I found this intriguing really to think about, because thinking about a birthday and celebration being very self-centered in the sense of it's one celebration of something. And so it would indicate that if that is true, that the use of lights and siren actually feeds more to the paramedics or EMTs own wants than what it's actually intended for, and that is the patient. And I propose that reducing lights and sirens really actually leads to more birthdays for our first responders and the public through decreased crashes, as we've seen some of the evidence presented here today. As responding lights and sirens without the evidence to support its use is dangerous to our public and staff that we commit to keeping safe. And I would suggest as EMS leaders, it's actually irresponsible for allowing this to happen within our organizations without the evidence to support doing so. We've talked a lot in EMS about psychological wellness. It's been a huge focus for first responders, and the reduction of the stress and the tension that happens in the cab of the ambulance. I'm sure for all responders there, I remember myself, the white knuckle driving and rush, 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 always go, 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 increases that stress and anxiety. And again, there's absolutely no evidence to support doing so. And so by reducing this, we really are addressing a number of safety and health concerns beyond that of the patient, but the provider as well. Next slide, please. So when we think about, this type of a change, the stakes are high. We often say we're not delivering pizzas. There's, big risk in what we're doing. But in our system, there was a huge risk, and that was a reduction of ambulances. In Ontario, we saw this huge increase in demand on 911 resources, with many EMS services at the time were sending out hot calls 60 to 80% of the time, leading to this depletion of resources and incidents of code 0 or code red, meaning that no ambulances were available. So the risk wasn't about taking too long to respond. It was about not even having a resource to send because they were exhausted when there was no medical evidence to suggest that we should have been using those valuable resources in that way. We have had an advanced dispatch center here as a prototype for the province. We've been beneficiaries of having the opportunity to do this for the province for the last 15 years. And over the time, we had made modifications to our system, and we were down to about 40% of all of our 911 calls going out hot. But with the bigger system transformation changes that we made, we knew we could improve on this substantially and get us down to that 10% that we're talking about. Next slide, please. So we really looked to the evidence to really figure out what was driving it. And if you advance, you'll see that our call volume, over a period of 7-8 years had increased about 50%. Trajectory predictive volumes show it escalating. We need to make sure that we were going to be sustainable. In a for-profit business, higher call demand, perhaps increased revenue generation might be a good thing. In our system, a single payer tax-based system, a higher demand means just adding more resources, which of course costs a lot of money. And so that's really unsustainable. And if you click again, you'll see that our resources to match that 50% increase were only at best 25% over that same time. So this was not a long-term solution of just doing the same and expecting a different outcome. Next slide, please. And so we really dove into the numbers and looked at our priorities, as they were going out, and did a lot of work on outcome when paramedics arrived. If you click again, Amanda, and one more time, you'll see that, what we really want to focus on our priority 2 were, some of those Delta calls, if you were to just kind of categorize them, that were lights and sirens, but we were finding that it was only actually about 23% of those that were actually emergent in nature. And so we were spending a great deal of resources in not being able really to support that with the evidence. And so that drove us to dig a little deeper. Next slide, please. So we really wanted to get into the data and the evidence. And so for our whole system modifications, we started looking at what the drivers were of why people were using 911, the reasons for their calling, the age demographics of change in usage, as well as future population demands, so we could anticipate what type of resourcing we would require into the future. And next slide, please. And that led to, as I mentioned, this complete systems change that we had implemented here in Niagara. So we went from a linear system that we're all familiar with of calling and sending a transport unit and going to the hospital. And if you click again, showing a more patient-centric model of mobile integrated health type of system delivery with a patient in the middle and a number of resources surrounding that patient. If you click again, please. What this led to was us to revisit our response policies, which leads to this discussion, implementation of other resources such as ECNS and other MIH specialty teams. And the big thing was a clinical response plan. And this clinical response plan really shifted us from being solely a time-based model to that evidence-based model using clinical outcome data to inform decision-making on how to move forward. And with that, I'm going to turn it over to Deputy Chief Farron, who's going to dive in a little bit on what that data looks like. Rick?
Thank you, Chief. So if you just want to flip to the next slide. So I just want to start out by saying this wasn't work that, just 2 or 3 of us sat in a room and sort of figured out. We had a significant group, a panel of medical professionals, everyone from frontline paramedics and dispatchers up to, of course, our own medical director, but also our own public health medical officer of health. We had primary care physicians represented, community care, and a number of different specialties. And we sat down and we worked through, what is this system going to look like? We needed to understand not just what is the right resource to send, but what time does it need in order to send that? And so that we don't find ourselves in a situation where we're unable to respond as a system to the most critical life-threatening emergency when that happens. So we looked closely at a lot of clinical evidence. We looked at a lot of the things that have already been presented by the panelists here today, Dr. Kupas, Dr. Cromer, and others, and looked at the use of lights and sirens. When does time matter? Does lights and sirens make a difference in time? What is the risk of lights and sirens? And came to the same conclusion that lights and sirens should be applied as a clinical procedure with a risk-benefit analysis. And when we rolled this out to paramedics, we actually talked a little bit about the principle of number needed to treat, which with medications that we give when they study the efficacy of those, of course, how many times do you need to use this in order to see the beneficial effect that you're driving for? And in the case of lights and sirens, a lot of times what we were seeing could be defined as medical futility when you use those parameters. So we decided that we needed to get this right to make sure that we have the right resources. In addition, we wanted to understand a little bit better about what paramedics were doing on scene. And we didn't have access to the paper that was just released in 2020 by Dr. Jarvis and others with regards to potentially life-saving interventions. But we did have access to our own records of what our paramedics were doing on scene, and the results were very similar. So in the Jarvis paper, you can see that 85% of calls, where they looked at almost 6 million calls, 85 or 86% were lights and sirens, but there was only 7% of those calls where there was any potentially life-saving intervention done. And that was using a pretty liberal interpretation of life-saving interventions as well. So we were looking at all of this stuff. And then finally, and most importantly, we did a literature review ourselves, looking at what sorts of call presentations actually could potentially have an impact on outcome when you look at time as a factor of that. And it's probably no surprise to anyone that's listening to this presentation that most of that literature came back related to cardiac arrest, which is, as we know, is a very small percentage of our calls. There was other things in there, closed head injury, some penetrating chest trauma, and a few other things. But for the most part, it was the cardiac arrest. And so when we went to the design phase of our new clinical response plan, we decided that we were going to be very cautious about when lights and sirens was used, and make that only in cases where we had a pretty good idea that it could potentially impact outcome. So next slide. So a little bit about nomenclature. One of the things we had available to us, we have an accredited communication center, so we use MPDS, and we have a pretty good sense that that is applied reliably, and so that certainly helps. And when you look at the MPDS system, you have your various different alpha to echo and some omega in there. You've got 6 different levels. We translated that into a 5-level system that was actually consistent with something called the Canadian Triage and Acuity scale. And so that is a system that's used in emergency departments in Canada and elsewhere in the world. And it's also used by paramedics in Ontario as a measure of acuity. And so when they arrive the patient's side, they do an immediate assessment of acuity, and then they do another one before they leave the scene. And we use first contact because that's before any intervention's been applied. And so what we were trying to do is anticipate, based on the data that we had available to us, when paramedics get to the scene, what is the anticipated acuity that they're going to find? And we came up with priorities and times, targets that sort of aligned with the recommendations of the CTAS system in terms of severity and in terms of time to see a physician. And so you can see that for those 5 priorities that we have in our system, there was just one that we decided needed to be lights and sirens. That was the priority 1, the one that sort of translated to resuscitation required. Priority 2, which was formerly lights and sirens as well in our system, we actually changed to discretionary for the paramedics. And that's a large part of our call volume. And I'll show in a moment what that looked like, but it's part of our change management process we gave paramedics the option that if they heard something they didn't like, they could use it. And we wanted to look at what that would look like in practice. And sort of as we transition through this change as a group, I think that helped considerably in managing some of the anxiety of moving down to such a small number. So if you move on to the next slide, this is just kind of showing when we did that, those priority 2 calls where we gave paramedics the discretion to use their lights and sirens. You can see that initially they were using the lights and sirens pretty frequently. And then as time went on and they became a little more comfortable with the system, the rationale, the design, that started tapering off, and it sort of leveled out around 18%. And so now we're looking at what is the next phase of this. We did some preliminary analysis to say for that 18% of calls where paramedics are electing to use their lights and sirens, what was the time differential? What did they save? And it's pretty consistent with the slides shown by Dr. Kupas earlier. It was about 90 seconds. And so now we need to look at, and what was the difference in outcomes, and bring that back to paramedics and evaluate whether we're going to carry on with that discretionary use or if that's something we eliminate. But even given that discretionary use of lights and sirens, we're now down to about 20% of all responses. 10% of our call volume. One of the other changes that the chief didn't mention that doing this allowed us to do was to actually start applying more resources to those calls deemed immediately life-threatening. So we started double dispatching on cardiac arrest calls and certain others. So it increased some of the resources that we're putting towards those most critical calls. So, next slide. So here are some of the results that we saw after year 1. Now, we started this system transformation. We did a lot of the implementation in September of 2019. And I want to say that, when we went through and applied the appropriate priority to each call, it was a MPDS determinant by determinant, line by line decision. It wasn't just you take an alpha call and you decide that it's going to be this priority and that's what alpha calls are. It was a line by line process, pretty painstaking really, looking at all of the data that we had available to us for every single MPDS determinant. And so, we looked at what the paramedic found acuity was for that particular determinant, what procedures paramedics had been performing for our MIH teams, what their success rate had been for that determinant to decide whether that would be part of the resource plan. And so after that was implemented, the changes to the response plan were implemented September 2019. And then after a year, we evaluated what the impact had been. And you can see that reflected in this chart. This is, again, quality improvement, not especially scientific, but in terms of the numbers that we saw, 5,708 incidents or calls that were lights and sirens calls compared to almost 25,000 in the year before. So as a percentage of our call volume from 42%, which was actually not bad given the context in Ontario, down to just 10.3%. And what was the acute capture? So when paramedics arrive scene and find that it's one of those CTAS-1 patients, one of those high acuity patients, previously, in order to get that 5.8%, we were running 25,000 hot calls. Now, out of 5,700 hot calls, that capture is almost 25%. So I tell our paramedics, you've got essentially, when we're running lights and sirens now, you've got a 1 in 4 chance of finding a very acute patient on the other side. So we know that there's some value into running that call hot. Of course, the other thing that you want to look at, and it's always a challenge for us, and what is the under triage rate? So you didn't use your lights and sirens and you got to the scene and you found a patient who was a CTAS-1, an acute patient. That number will never be 0 in any system unless you're going to all calls 100% of the time hot. Right? So in the year prior, it was 0.7%. And in the year after, the raw number was 1.3%. But then we looked at the calls where paramedics had elected to use lights and sirens. And when you put those ones in, then the adjusted rate is 0.9%. So those numbers aren't statistically significant, but it is interesting to note that at the end of the day, There was an awful lot of reduction in risk without a significant increased risk on the other side, on the patient side. The next slide. Oh, yeah, I did mention that part too. 20% of all responding vehicles. So 10% of incidents translates to about 20% of responding vehicles. So a motor vehicle collision or cardiac arrest, you may see multiple vehicles responding with those lights and sirens. And the only other thing I'll add, and I didn't speak about this, but a lot of the discussions and some of the questions I've already seen, it occurred to me is, as a system, how do you measure performance when you make a change like this? Is it only the lights and siren? What is our response time as a system? And that's obviously still important for those priority 1 calls. What is your response time as a system? But how else do you measure the success of your system and the performance of your system? And that's looking at clinical performance indicators, things like how well are you as a system at relieving pain? How well do you as a system implement protocols for stroke, for STEMI, select the right destination? How well do you as a system adhere to, you comply with your own response plan? So if your response plan says we need an advanced care paramedic on these calls, how well do you as a system do at making sure you get that resource there? So this change goes now into a bunch of other discussions about how we measure success as a system.
Great. Thanks, Rick. Appreciate that. Lots of great information there. I think we're going to send it over to Robert McClintock, who's going to wrap up at least our speaking portion, and then we can get to some Q&A stuff. Robert.
Thank you, Chief Smith. So the IFF, one of the IFF's primary missions, right, is the health and safety of our workforce and the public that we protect. We fully support, right, evidence-based guidelines and performance metrics that keep our workforce safe. With that being said, I think that, you know, when we look at this and the implementation of such a type of a system where we're going to go no lights and sirens, right, it has to be very locally driven, department or agency protocol specific, but it needs to include a lot of things. There's a lot of components here that need to be looked at. So we talk a little bit about your community risk assessment of incident density, right, to make sure that you're matching resources to demand. Right. And then there's the customer expectations, right? So customer service, customer expectations aspect of things that when we look at that, it's very important to take that into consideration. More importantly, you know, engaging all the stakeholders and getting everyone involved, including your city administration and everyone to kind of understand the science behind these decisions and the safety. So another great avenue is public education. So I think if you engage the public education campaign worked great for the 911 system. As we all know, no one is afraid to pick up the phone and dial 911 to call for an ambulance. However, we now kind of need to re-educate the public that not everything, right, is a life threat. And, you know, so that's a big part of this component is making sure that we meet their expectations and do a little public education campaign to kind of, you know, allow them to expect that the ambulance isn't going to arrive in that, you know, 8 minutes or 4 minutes or whatever the case may be. So protocols should be developed with the guidance of your medical director. That is really, really, really important to have your medical director do an assessment of the system, do QA, QI, review of the calls, review data collection, and then the ongoing evaluation. The dispatch, you can't do it without them, right? We know that. So it's very important for them to be involved in this process. And it's important for them to be using an improved emergency medical dispatch system to triage the call appropriately. They too should have a robust QA and QI system in their process and work close conjunction with a medical director or the medical director for the EMS system. So those components are really important to get that whole system, you know, designed and put into place. Next slide, please. So here we say no excuses, right? So here, what we're meaning here is that departments and agencies, right, you still have to provide those adequate resources to meet the demand. You need to set those reasonable response times based on the priority levels. And then evaluating just as needed to maintain the safe and effective operations is just a really important key here. And I know I saw a question in the QA box already. This should not excuse any agency or department from properly training their personnel in emergency vehicle operations. I know the IFF is in partnership with NHTSA for their traffic incident management system and safety that they do for that training as well. It's very important to not overlook these things, because if you are going to be going lights and sirens less when it comes time to use the lights and sirens, you may lose some capability there, just like we do when we don't do procedures on a continuous basis. So I am going to turn this back over to Matt so we can kind of get into the live Q&A that we have scheduled here for this remainder in time.
Fantastic job, everybody, and great information. The Q&A section in the chat going crazy. So we're going to try and amalgamate some questions down to some of the themes that we're seeing come across the Q&A. And the first and probably most prolific question that's come across is this concept of community expectation. The public expects us to respond hot to their 911 call. The patient might not feel that we really care about their medical complaint if we don't respond lights and siren to the call. Kevin or Rick, in your system, what has been the public's reaction to your change? And did you do anything to prepare the community as you began this change process?
Great question, Matt. And this is certainly, one of the big things that you want to think about before you just radically change a system is the different people that are going to be influenced and impacted, and particularly the public. And so it was interesting because when I talked about the big system changes we made, we weren't focusing just on lights and siren response, but we actually did survey the public. We had several mechanisms of engagement with various cohorts within our population. And I believe that's actually going to be released a paper or something. Rick's nodding his head. I know we did it through academic institution because we went in with the same beliefs and biases that's what the public expects. And we were surprised to actually see that wasn't true, that the public does expect you to be there when it is a true emergency and be there quick and get them to a hospital. But they are quite, I'll say, content or satisfied with a response that involves everything from just knowing that you're coming to, I'll talk to a nurse and maybe they can provide an alternate resource for me to go to. So I think we need to challenge those biases and that thinking and our preconceived. Maybe, that was the notion years ago. I saw in the chat box, that there's a belief that somebody in the community feels better when they hear the sirens coming from a distance. And that may be true in a very critical situation. But as I believe it was Dr. Kupas, that's not always true and is actually a reason why people don't call for us. So we did a lot of that survey. We put together some infomercials that run on local media and YouTube. And we can share those links with you. If you Google us, you'll see little cartoon infomercials that got a lot of input and uptake. And then we also, engaged primary care. So videos ran in doctors' offices, local media, local television. We did all of that to make them aware of the changes that were coming.
Excellent. And, we often say that we gave the public the expectation that they were going to get a light and siren response. So really that expectation was created by us. We need to be the ones to change that expectation. And to what Marie Wilson found, and I was in Connecticut as a provider when she did that study, Dr. Kupas, you'll appreciate that. That was when we still had horse and buggies that we were responding in. And it is the quiet confidence that makes the difference. Dr. Wilson, you have been prolific in answering a whole bunch of Q&A on the chat in the Q&A section, so thank you. But what do you think about this entire concept in your experience and some of the things that you're seeing not only in your local community, but also the reactions that you're seeing from some of the folks that are on this webinar?
So it's very interesting because my my grandfather is quite ill and has had a call for an ambulance to take him to the hospital a couple of times, or rather I've called for him. And he's been very angry about that because he doesn't want the lights and sirens and the riffraff showing up at his front door. And so it's interesting because I'm living out that opposite expectation to what some people here have kind of said. Personally, I have found, those same negative responses. Patients come into the ER and say to me, oh, they didn't even come lights and sirens. or you show up to the scene and you're working with the ambulance crew and they're like, you guys didn't even come, lights and sirens, what's wrong? And 30 seconds of a professional conversation explaining why lights and sirens is an intervention selectively applied to keep them safe, keep the community safe, making sure that people know that we have dispatchers that are highly trained, that we use these dispatch, protocols so that we can get the right questions, so appropriately select patients to get there. And then let them know that, despite the expectation that it saves time, systematic studies have not shown that it reduces time significantly. Yeah, there's definitely times you can get through the stop traffic on the bridge, for example, it's a choke point. But by and large, there's not a lot of change. And I find that most patients and their families, when you explain that to them and then continue to provide high quality professional care at their bedside and transport them safely to the hospital, that they're fully understanding of that entire situation.
Excellent. Thank you. Sort of along the same lines, we've had a couple questions, and one of the ones that we had put in the queue for Rick and for Kevin to address, what has been the reaction from your workforce? Because a lot of people, and we've heard at conferences that people, especially in smaller agencies or volunteer communities, hey, if we stop responding to calls, lights, and siren, we will lose employees, we will lose volunteers. What has been, Kevin and Rick, the reaction from your workforce about this change in procedure?
Rick, do you want to answer that?
Sure. It's been a significant transition, I will say. Not everybody has been completely comfortable with all of the decisions, and that there has to be a way to address that. And so there are avenues for paramedics or SSCs, what we call our emergency medical dispatchers, to forward those concerns through to the committee, and then the decision is reviewed and we do an analysis. And in a couple of cases, based on feedback from staff, we've actually gone in, revisited, and now with the addition of patient outcome data that we have at our disposal, reconsidered some of the changes that were made and added some other calls to the priority 1 category, or in some cases lowered them down. And so I think the key is staff need to really understand why we're doing this, the whole safety piece, as well as making sure that we can get the resources to the most critically ill when that time comes. And they need to have an avenue to be participative in that process. And so we've put that in place as well. And so we just launched as of June 28th, we just launched the next iteration of our response plan. And one of the things I didn't mention in my presentation is we now have access to linked patient outcome data. So I can go in and run reports by every single MPDS determinant and look at 1 and 7 day mortality, admission rates, times, ICU admissions, what happened in the ED. And now we add that additional element to all of the information, and it's really given us a few eye openers. Things that we thought were a lower priority are suddenly bumped up, and vice versa. Interesting look at 6 Charlies. Well, by the way, they're probably scarier in the outcome data than 6 Echoes. But anyway, we are involving paramedics along the way in how we're doing this, and that's key to all of this.
Yeah, communication and using evidence to base your decisions and sharing that information with your workforce. Excellent. And Rick, you just mentioned the outcomes. So for Dr. Kupas, Dr. Wilson, Kevin, anybody who, Dr. Kramer, there's been a lot of questions in the Q&A about, has this change made a difference in patient outcomes? Because we really want to be driven by patient outcomes. Have you seen an improvement or a detriment to patient outcomes because you're responding now to only 10% of your calls, lights and siren, depending on the discretion of the crew?
I see Dr. Kupas has his hand up.
Go for it,
Dr.
Doug.
Kupas.
Sorry, as I was speaking on mute, I was going to say I can take a shot at that. So, I think, first of all, if you look at the data, the lights and sirens are detrimental to patient outcomes if they kill the patient on the way to the hospital, or if they cause an ambulance crash that further delays the response and that sort of thing. Will we ever find that lights and siren use is beneficial to patient outcomes? I'm not sure that a study will show that, but I think that the bottom line is we should be continuing to look at this as a medical treatment. It's something you're prescribing and doing. And, what happens when you get to the hospital? I like the fact that Niagara has started to drill down all to the point of what happens in the emergency department when the patient arrives. Who gets a emergent, emergent cardioversion, emergent intubation, that kind of thing as you roll through the door. What most people probably, if they're in the EMS business for a while, realize is that they spend a lot more time where they bring a patient in, they stand along the hall wall, the wall time, so to speak. And many times they stand at that wall for a lot longer than the 3 minutes max that they saved on the transport. And, nothing is happening to their patient in that time. So, it's really that very, very small group of patients that benefit by it. In 1993, my first research project was medical criteria limiting lights and siren transport. And we looked at outcomes. And what we found at that time, 8% of the protocol we used, 8% of the transport were with lights and sirens. So for 1993, that was pretty amazing. For today, I'd say that's way too high. But we followed the outcomes of the patients that did not get lights and siren use, and we could not identify any patients that had any worsening because they didn't get to the hospital that much sooner. So I think it clearly causes an issue if you cause an unnecessary accident. It's very difficult to say who's saved by that 2 minutes. And, EMS, the emergency should be over when EMS gets there. When you talk about the transport side, there's very little that EMS cannot do that needs to be done within a minute or two on arrival to the hospital. Some similar things could be said about the response side.
Yeah, absolutely true.
Matt, I just want to jump off what Dr. Cooper said there real quick. There is empiric evidence that we have now of how recently or how quick upon arrival do we need to do these time-sensitive interventions. And I'm just going to call everyone's attention to the study by Dr. Jarvis and Mike Tagman, who I believe is actually on here as an attendee. And I'm dropping the DOI to that in the chat for everyone to look at. I do believe Rick and Kevin referenced it in their talk, but there's just another piece of data for people to look at that's current.
Yeah, and that's great information. And even in a cardiac arrest, the first responders generally are going to get there relatively quickly, a neighborhood fire station, that kind of thing. But when we implemented at MedStar the cold transport for any CPR case, so CPR cases, safer for the crew, give better CPR. We measured CPR with and without lights and siren. When we measured the time, the light and siren transport actually saved about 2 minutes and 10 seconds. But the crew on average took 3.5 to 4 minutes once the ambulance was in park to get the patient out of the ambulance and into the emergency room. So we worked through a process to improve the process of discharging the patient from the ambulance that more than made up for the time that was saved in the cold transport. So very, very much so.
Matt,
go ahead, Dr. Kramer.
Just throw in one additional comment, and this applies to ambulance crashes not only associated with lights and siren, but when lights and siren weren't used. But remember that over half of the individuals that are injured or killed are not the ambulance crew or not the patient when it's associated with a crash. So there is an unbelievably significant impact on the community in these events.
Yeah, excellent point. First, do no harm, right, Dr. Kupis? That's the mantra that we really try and stick with.
Primum non nocere.
I think one other point just to emphasize, and we heard Chief Smith talk about the ACE accreditation, and I know we've discussed this offline, that you have to have a degree of confidence in the ability of your 911 center to actually triage these calls and put them in the appropriate categories. And if that piece is not in existence with good quality improvement, good quality assurance, then you can't really go too much further from that point. And I think that's essential to any system that's trying to make a change. And we've talked a little bit in the chat here also about the other end and quality improvement metrics on the back end of this. And I think that's an important piece in addition to what goes on in the 911 center is being able to have some metrics that you actually apply to this retrospectively and look at what you're doing. And so those are available from a number of places nationally. The NEMSQA, the National EMS Quality Alliance, has a project that allows agencies to apply that to their data, and probably each one of your PCR vendors has something that you could use to actually look at those metrics.
And Mike, you mentioned NEMSQA, and I think we talked about it on the prep for this. There is a NEMSQA project currently underway. Mike Tegman had mentioned it in the Q&A. Somebody want to comment on the project that they're getting ready to launch or is currently underway?
Sure. I know I'm working as part of the group on this project, and it's super exciting. This kind of came as a brainchild out of the National Association of EMS Physicians Quality and Safety course that we run every year, where we were kind of talking about this. That was my project last year, was focused on lights and sirens, where I cut our use transporting almost 80% down to only about 1% of our transports, which is I'm super excited with. And just a lot of us were talking together about coming together, sharing ideas, and really trying to push evidence-based practices across the country, and getting a lot of people together so that we can focus on some of these community-based concerns that people have. We talked about education and sharing ideas and just kind of getting it out there to people. So the National EMS Quality Alliance partnered with, NAMSP, and I'm sure NAEMT and a bunch of other stakeholders are working together to put a team of kind of subject matter experts. A lot of us are probably on this call right now, actually, to start trying to develop a nationwide quality improvement project so that we can just try to keep our patients safe and increase the quality of care that we deliver everywhere.
Excellent. And one last question before we do some closing comments from the panelists. Rob, this might be a good one for you. There were a couple of comments in the Q&A section, and you mentioned it in your presentation, about the quality of driver education, and also, because I know the IFF has done a lot of work on fatigue in the workplace and looking at that. What factors do you think might play into, or what assurances can be done by agencies with regard to training and worker fatigue when it comes to crashes involving red light and siren responses?
Yeah, and that's a really great point, Matt. And I think some of the training, to be honest with you, involves more so on the management side of how to recognize fatigue and how to manage fatigue in the workforce. And that kind of goes hand in hand with making sure you have enough resources to meet the demand as well, because you want them to, we don't want to burn our workforce out any more than they already are. So it's important to meet that. The training aspect of things is just, it's a huge component. I know we on the fire service, we've always focused on driving a big fire apparatus, and we give little attention to focusing the ambulance, even though the ambulances are going on a lot more calls. So we don't focus as heavily on that sometimes, and we really need to put that focus on, driving any vehicle, right, with lights and sirens. So emergency vehicle operations course is really good, and like I said previously, partnering up with NHTSA and doing the TIMS training is important to keep our people safe on the roadways, at road scenes and things like that. So training is a key component, but like the fatigue management can definitely need some help too. So
Technology is a big piece of that as well. I mean, we have, and I think Rob would agree with me, that our fire trucks are a heck of a lot safer than our ambulances because we've employed a lot of technology over the years. And you look at passenger autos that essentially drive themselves, and it's kind of difficult to crash some of these cars these days, and yet an ambulance has very little of that technology incorporated in it, and it really should have a lot more than it does.
So Dr. Kramer, in your autonomous vehicle work at NHTSA, make sure you put ambulances and fire trucks further up on the list so we can have autonomous driving fire trucks and ambulances, right?
There are a lot of discussions that are starting to be had about both of those issues. Yep.
All right. And I haven't been able to see it recently, but for the panelists, are there other questions that have come up on the Q&A? Or Amanda, have you seen a couple that have come through? Looks like Dr. Kupas has a burning question that he wants to answer?
Well, there were a couple related to liability, and I want to set a few things straight there because, and not to speak to any individual one, but there were certainly lots of anecdotes and I think misinformation in there. I mean, to me, here's what the facts show as I see them. Number one, lots of EMS agencies have been sued. It's one of the highest reasons to be sued for crashes that you were involved in or people you've injured in a crash. So I think that, I'm not aware of any great groundswell. And I have seen lists of like the most common things that EMS agencies are sued for. I have not ever seen anywhere even on that list being sued for failure to respond with lights and siren. So I think this idea that it's liability to not use the lights and siren. People have asked on the chat, what do liability companies or insurance companies think? I think if you ask people in insurance companies, they would say the best thing that they would love to see is take all the lights and sirens off of the ambulances, because that would make their liability much less. Not the opposite. So, this is not really something where liability should come into play dramatically. And, people should also realize that when we talk about reducing your hot responses, if that call has a certain category of response, or it comes in as a 911 call, we're not talking about, we're now going to set that on the back burner and go to lunch first. We're talking about, you're going to promptly go to the vehicle, you're going to get in the vehicle, you're going to go to your assigned call, and you're going to save 2 or 3 minutes max, and maybe more like a minute and a half. And so that's really what this is about. And for the vast majority of patients, they do not need that.
If I could jump in, Matt, just building on a couple points, I'm glad we brought this topic up. Just on the last point there, Dr. Kupas, that's exactly where we saw the difference between our priority 1 and 2 calls, where the priority 1s are mandatory lights and siren, priority 2 right now discretionary. Other than that, everything is equal. We treat, the same urgency of getting it out the door and assigned properly. It's just the actual the response time of driving time, right? And that very little differential. But I did want to go back to the risk, in lights and sirens, using it, not using it. And, thinking back to some of the drivers, as I mentioned during our slides, to us, there was a bigger risk in not having an ambulance to send at all. And to me, and to your point, I think that is the more responsible and accountability that we have to our public, is to preserve those precious resources the best we can. As leaders, that's what we should be doing. And to be using them indiscretionately, or at least when there's no evidence to clearly support using them in that way. I was more concerned, and my team was more concerned of us just not having someone to send, and it becoming a litigious situation, where there's a poor outcome of a patient and we couldn't justify not having a vehicle. So I'm really pleased that this conversation has happened, because I think those are some of those biases and the barriers of preconceived beliefs that we've had for many years, that as leaders and as providers, we need to champion and have that change within our own organizations and throughout as far as we can.
And Dr. Kramer, you had a comment as well?
Actually, I'm going to hold it. I was going to make an anecdotal comment, but since I can't reference the source for my anecdotal comment, I'm not going to say it.
Never stopped you before. No, I'm just kidding. Everybody makes a good comment, and one of the comments, the Q&As was, if we don't respond lights and siren, we're going to be taking resources away from patients because our cycle times be longer. Was the inference. But it was always told to me that when an ambulance crashes on the way to a call, you've taken 3 ambulances out of the system. You've taken the ambulance that crashed, you've taken the ambulance that is now responding to that crash, and you have to cover the original call. So getting there safely is always the best resource allocation. Other comments from the panelists based on what you're seeing in the chat?
I just, to take off what you just said, Matt, there, right? In the fire service, right, we talk about, everyone goes home, and safety is such a big thing. Lights and sirens have just been shown to be, overall just wildly unsafe, and just an independent association with just badness. we need to go home to our families at the end of the day. We need to be available for the next patient, and we want our patients to go home to their families after this medical episode's over. You know, and unless we, you know, find a specific time or place when lights and sirens do aid in that recovery and in those mortality outcomes that we're looking for, those morbidity outcomes, it's really just risk at this point. And I think that's the thing to remember is it's, you know, public perception is one thing, and we can find ways to manage that, you know, but I don't know how to manage the public perception of the family member for their loved one who died when the ambulance crashed going through the stoplight. And I do believe mid-May, end of May, there was a fatal ambulance crash. I believe that was in Michigan. You know, and I believe a paramedic and the patient both succumbed to their injuries from that accident, you know, and it's devastating.
Yeah, you know, if you want to do something sobering, I've had the blessing of going to the National EMS Memorial Service a couple of times, and it really strikes home when you realize how many of the memorialized people that were going through the EMTs, paramedics, firefighters that are part of that process were killed in vehicle crashes going to calls and or helicopter crashes, but we'll have that as a separate conversation. But that is the biggest risk. And you start to wonder, you know, is it really worth it? You know, was that 2 minutes actually worth the both people in that ambulance that succumbed from the crash? So if you have a minute, look at some of those, some of the data from the EMS, National EMS Memorial Service, and you'll see truly the impact that this is having on our workforce and on our profession and our people. So other comments from the panelists before we say some thank yous?
I'll just chime in because I'm less of a lights and siren junkie than I used to be, but even when I'm doing field days with the agency and with my EMS agency, not with NHTSA, you know, when a crew is dispatched, even on a Charlie or Delta response, and it's the other side of the county, and it's going to take me 25 minutes to get there, there's a real overwhelming sense of, well, let me flip on the lights and siren and I'll get there 2 minutes faster just after they've loaded the patient into the vehicle and are starting to transport them in. So, you know, it's a real reality check of, is it worth it? And, you know, that's something that folks have talked about on this webinar. I think it's a reasonable question to ask every time you light up the vehicle. The other comment that I'll make, and I appreciate the comments that have come from the Niagara system, this is a culture change, and the culture change includes not only the clinicians who are in the vehicle deciding whether or not to turn on the lights and siren, but as you alluded to, the folks in the communications center, and more importantly, the leadership and management. You know, there are still leaders out there who grew up responding lights and siren to everything and are saying, if they call us, we're going to light it up and we're going to go. And we got to change that mindset.
Matt, I'd like to, as a closing thing from me, just say, I think we need to think about what the real purpose of what we do is. And it's about taking care of our patients. And, you know, patients expect a caring, compassionate, calm provider. That's really what they want and what they, you know, appreciate. And, you know, in the days where we are starting to, you know, respond and take people to an urgent care, respond and treat people at home, you know, our goals and our providers need to change that culture to, you know, it's not about that fast lights and siren, you call, we haul, that's all. And it's about providing healthcare to people with what they need. And increasingly, that is not even going to be transport to the hospital. So it is really difficult to justify the lights and siren response to somebody that you take to an urgent care or that you treat at home.
Yeah, absolutely. And a great way to sort of close out this part of the conversation. Gentleman, lady who helped coordinate all of this, I really want to thank Aim High. You saw we had AAA, International Association of Fire Chiefs, International Association of Firefighters, NAEMT, NHTSA, just a tremendous collaboration. So clearly we are aligned on this issue of really trying to manage this process for the benefit of our workforce and preserving our workforce. I want to thank these gentlemen. They've put in a lot of time and effort in putting this together. I think we all need to give Amanda Reardon also a round of applause for keeping us all on task, quite frankly, and making sure that all the technology worked. So Amanda, thank you very much. You did an amazing job. Several of you asked that a recording and the slide deck will be available shortly. We will send out that to all of the registered attendees and make it available to the public, because we do think this is something that everybody in our profession really needs to understand. And we need to work together more to try and make the use of Lights and Siren a true clinical decision and not just an operational necessity as we kind of move through this forward. So with that, if you guys don't have anything else, we'll go ahead and close, let people get back to their day. And thank you all very much for being part of this. Very valuable.